Hello, dears. After a very good night in Berlin, very good sleep, I see everybody is happy and untired. Huh? So today we will talk about several special issues. Now it is our pleasure to co-chair this with Iko. I miss you, Iko. Let's co-chair this with me.
Yeah, thank you, Murat.
And word from you before the start of the session.
Yeah, I just said that it was really a long time that we were together. It's not the best we can chair this session together. Yes. And we really would like to warmly welcome our first speaker in our session, Desislava Dimitrova from Charité Berlin, and she's going to talk about the hormonal substitution in gynecological cancer treatment. Thank you for coming.
Hello, good afternoon, everyone. Dear Dr. Gültekin, dear Dr. Todd, dear engaged members, it's a great honor to be able to speak today, and I want to give you an overview of the possibility of hormonal substitution in gynecological cancer treatment. When we need a hormonal replacement treatment at first place, it's in case of menopausal symptoms, in case of ovarian insufficiency due to surgical removals of ovaries or chemoradiotherapy, or in case of primary ovarian insufficiency. The menopause could be defined retrospectively with a period 1 year without menstruation, and it represents the ovarian transition from normal function to ovarian failure, which represents in first place with estrogen deficiency, and the median age is around 51 years. Experience it like under age of 45 or even under age of 40, which is like the premature ovarian insufficiency. And how we defined it, it's based in first place on symptoms, on the last period in this time of cycle gets irregular, and sometimes it's difficult though when the woman had a hysterectomy or endometrial ablation or IUD. In such case we cannot have the bleeding, but then we have the symptoms like hot flashes, which can give us a hint, or sometimes it's needed to make some hormonal diagnostics, but it's rare. It's mostly in the case with primary ovarian insufficiency, where we measure the estrogen levels and FSH, and if it's above the 25 units in a measurement of in 2 measurements in a range of 4 weeks, then we speak about primary ovarian insufficiency. And what are other major symptoms apart from the irregular bleeding? It's the vasomotor symptoms, which includes hot flashes, also very common the recurrent urinary infections, and also other concerns like osteoporosis, cardiovascular risks, which are a theme. And if we see what is the role of estrogens, we can explain, because the estrogens is one of the most important hormones with very multiple functions in our body. It's not only for the reproductive system important for developing of uterus, of the breast, but also in regulating the metabolism. And we have different types of estrogen receptors, as you can see here, and the different estrogens like estrone or the estradiol can bind with a different affinity to this receptor, so they can sometimes have different effects. Women had hot flashes. It's quite a major number, around 50 to 85%, and 1/3 of them have really symptoms over a period of 10 years, which is long period of time, and we don't know why they exactly occur, but one of the theories that's a dysregulation which results in an abnormal response to a minor elevation of the core body temperature. And there are some risk factors like obesity. Another common symptom is the vulvovaginal atrophy, which leads to dryness, recurrent infections, and it's present in around 50% of the women with postmenopausal symptoms. The main reason or problem is due to estrogen deficiency, exfoliation of the vaginal epithelium, and also the glycogen, which is very important for the functioning of the normal bacteria in the vagina, is dropping, and it leads to a pH of the vagina going high, so other bacteria can prevail, and that could explain sometimes the overgrowth of other bacteria and the infection increase. Also, as I mentioned, in bone metabolism, the estrogen play a very important role. In first place, with stimulation of the osteoblasts and inhibition of the osteoclast mineralization. And we have these 4 approved indications for hormonal treatment. That's this vasomotor symptoms, prevention of bone loss in case of premature ovarian insufficiency, and genitourinary symptoms. It's hormone replacement treatment doesn't provide contraception, and if it's 1 year after 50, this transition, then also contraception issues have to be discussed. And there are certain contraindications where we cannot apply hormones. We have another alternatives, but that's at first place patient with breast cancer, with estrogen-sensitive malign tumors, with undiagnosed genital bleeding, with endometrial hyperplasia, with acute or recent arterial or venous thromboembolic disease, also untreated hypertension, acute liver disease, and porphyria cutanea tarda. We have different forms of applications like oral vaginal rings, patches, or gels. And it's very important to state out if the uterus is still present, intact, we need a combination of estrogen and progesterone. And we need a sufficient dose of progesterone, which should be at least 4, and progesterone. And we need a sufficient dose of progesterone, which should be at least for 10 to 12, and better 2 weeks per month, that we achieve endometrial protection. And there's also different dosages, low dose. If it's the case of supplementation, like the primary ovarian insufficiency, we are giving moderate to high dose, and also, as I mentioned, with combination with progesterone. There are some issues which occur from big studies. About the safety, and one of the biggest examples is this Women Health Initiative's clinical trials, which is a series of clinical trials which include a major number of women, 160, 800,000 in a period from 1993 to 1998 in USA, and there are both arms. One was with combined hormonal treatment, one was only with estrogen. In this case, they didn't have the uterus. So the study had to be stopped prematurely because there was increase in the breast cancer risk, in strokes, events, in heart attacks. But it's also very important to state how the results are interpreted and look at the absolute risk. What means, I mean, that's just numbers, but still, when we look at how really the incidence is increased, we see that we have per 10,000 women, plus 7 cases with coronary heart disease, plus 8 coronary heart disease, plus 8 cases with stroke, with venous thromboembolic disease was much more, 18. In breast cancer, we had with a combination plus 8 cases, but in the monotherapy, we have even less cases. And also for osteoporosis, reduction of the risk, and for diabetes, it was also a reduction. So it's very important that we stated that this population of the patient in this study was with high risk factors. They were mostly women above the age of 65. There were arterial hypertension, and 10% had also additional risk factors, which is very important to state. And as you see here, it leads to a prescription drop of the hormone treatment. But if we look closer at this population and choose the women between 50 and 59, which is the group of women we want to achieve actually, which have the severe symptoms, in this group it even reduced the risk for heart disease, because the initial goal of this study was to see if it's protective for heart disease. And that's why it was postulated that we have windows of opportunity where we have to start the hormonal replacement treatment in a certain period after the menopause, and not later than 60 years to achieve this protective. And indeed, some risks are increased, but they are stated as low. Everything which is 10 of 10,000 is as low risk. And in case of stroke and breast cancer, it was increased, but it depends. But it depends on one side on the progesterone which was used and of the time of the application. We can see in a study from France, they prove it here. They just make several groups with different kind of, when we see here, one means that's no increase of the risk, and if it's like in the case of dydrogesterone, which is also with low risk, then we see that progesterone, which was in this study, the risk was much higher. So it matters which progesterone we use. And about the venous thrombosis risk, we have indeed this increase when we use oral estrogens. In case of transdermal application, we don't have risk increase, and the risk drops over the years. As you can see, from 4 here to 2 over the next 1 year. And in the case of stroke, there's also risk increase, but also here a big study with almost 100,000 women from Denmark stated that when it was a transdermal application, it doesn't change the risk of stroke. But for oral application, there was a slightly increase of the risk. And what about the risk of breast cancer? What we know that application of hormones after treatment of breast cancer leads to increase of the recurrence risk. And it was true for hormone receptor positive, and hormone receptor negative cases. So we don't recommend it. What we have as alternatives in this case, we can use other kinds of approaches like serotonin inhibitor reuptakers, even hypnosis or acupuncture. That's also a possibility, but we have to see what's the patient preference. Sometimes there could be individual decision to apply hormones for local. It had to be discussed that there is some risk increase. And about endometrial cancer, it's interesting to see that in certain population which have their risk due to other factors like obesity, even a hormone replacement treatment can even reduce the risk. We don't use the hormones to prevent, but as you can see here, it's one is no risk, and when the women have BMI like 20 or like 42, risk is much, much higher. And if we use the hormonal replacement treatment, it drops to 2. It's a risk reduction. And it also depends if we use the hormones, how many years we use them, if we use them continuously or if we use them sequential. That means if we give the progesterone 2 weeks or we give it continuously without interruption. And as we see here, in case of continuous combined application, it was with the most risk reduction. And what about this hormone replacement therapy after a diagnosis and treatment of endometrial cancer? There is, for example, one big study which included almost 2,000 cases, and there was comparison of the women who received hormonal treatment after the diagnosis and women who treatment after the diagnosis and women who didn't receive, and they stated that there was no increase in the risk of recurrence. But we have to state that these studies are with early stages of cancer, so if we can on free, and but as it's stated, it doesn't increase the risk for recurrence. Another situation is in the uterine sarcoma, which are mostly estrogen sensitive. In this case, we will avoid the hormonal treatment. And what about ovarian cancer? And what about ovarian cancer risk? If we give hormone replacement therapy, there is, after 5 years, a slightly increase in the risk, but it was very minimal. One of 1,700 women, one which is stated as a low risk. And after the treatment or after operation, you can see that there in this study it was again the one is no risk increase, and under one is even risk reduction. It was not increased after the hormone replacement treatment. And it's important to state because some women get, due to ovarian tumors, they are go in very early menopause, this surgical menopause, and it could have major effects on the bones, on cardiovascular system, and even dementia risk, and we can, in this population, decrease it with a hormone replacement therapy. There are some exceptions, like granulosa cells tumors, hormone sensitive, then we cannot give this, but the others one, which are repeated ovarian cancer, they are mostly hormone, not even hormone receptor sensitive, so we can give this option for women who are in the premature ovarian menopause. The bones protection, it will be like with a patch will be 100 microgram. If it's a gel, it's 1.5, and oral will be 2 milligram. And very important, if the uterus is there, that we have also progesterone. There is some alternatives if we have if we cannot use hormonal treatment. The phytoestrogens are discussed as possible alternative. That's compounds which are based on plants. They refer to 3 groups, mainly isoflavones, lignans, and comestans, and most popular are based on soya products. Also, there is studies with them at different dosage, like between 30 and 60 milligrams per day, that they can change the vasomotor motor symptoms. Also, they resemble the estrogen, but they have other mechanism of action, not completely clear, but what's important, they have also some anti-estrogen effects. And in this case, they even there are some studies with hyperthium perforatum, which was also showed some effectiveness. Other substances like YAM in other studies didn't show any effectiveness, but what have to be stated that most of these studies are too small to make suggestions to use these substances, and that we don't have a strict dosage. And if you have someone who is recovered from breast cancer, we will not recommend to use them because we cannot control the effect. But it's the option. In summary, I want to say that the hormonal replacement treatment is one of the effective therapy for vasomotor symptoms and bone loss prevention, that the individual risk of the patient should be evaluated before starting of the therapy, and that we have this window starting of the therapy, and that we have these windows of opportunity which have to be at optimal used to start the therapy, and we need to regularly reassess if the hormone replacement therapy should be, if the symptoms are still there, and if something changed. That was my presentation. I am happy to answer your question.
Thank you so much. Desislava, it's a very complex topic, and when you have done a review of the literature, it's one of the hot debates, even among the doctors. We don't know the correct answers. But let's start with, first of all, some questions from you. Maria. Yes.
I want to ask you about the biomimic hormones.
Bioidentical hormones, you mean? Yes. It's the same with the phytoestrogens. I mean, they are widely used in USA, but the problem with them is they also have a very different prescription. So we can, the positive side is they have different estrogen in one prescription. So maybe in some cases they are very helpful. Of the other side, it's not controlled, and we cannot say we have 1 milligram, it's exactly 1 milligram. I'm not, but the official recommendation is that we don't use them as like standard. And also very important for the progesterone, there is several gels. What is important to state that the dosage is important to state that the dosage is very low, so it doesn't reach protection for the endometrium if you apply progesterone gel. It may be help for the other symptoms, but if you need to protect the endometrium, you have to apply it orally or vaginal to be enough resorbed, other resorption. So the patches is, they are combined. The patches is okay, but the gels.
I'm using patch. Any other question? Any other question? So let me to ask you, who have used these menopausal hormonal treatment? Hands your raise. 10 to 15%, right? That's
Yeah.
10 to 15%, right? That's
Yeah.
20%. I think after WHO, many of the doctors unfortunately stopped, first of all, to give menopausal hormone therapy to the, as you have already stated. This study was wrongly planned. Don't forget, I mean, this was done in the United States, and the median age of this hormonal treatment group was 62 or 63. Which is not the typical age range that we are giving.
Yep.
We are giving this hormone when you were perimenopausal period between 50 to 55, let's say, and save your bones for 60s. So if you, of course, give to the ladies, elderly, 60, 63. Then you face stroke, emboli, and then you face some sorts of cancer. Stroke, emboli, and then you face some sorts of cancer. Unfortunately, but millions of women did not receive any hormonal therapy for the last 2 decades.
That's very sad, because
That's
it's
very
really
sad.
interpretation, and even the authors published it later, and this misinterpretation, but it leads to the drop of the hormone prescriptions.
Unfortunately. And I'm talking about not cancer survivors, general female population. I prefer, for example, to use oral contraceptives. Oral contraceptives. It's also risky, but it has the hormone. It really, it's very nice for your flashes, vasomotor symptoms. And at the end, if you look to the data of oral contraceptives, it's different than hormone replacement therapy. Okay, these are combined oral contraceptive, and then you have menopausal hormone replacement. These drugs are different, but oral contraceptives are more cancer protective. If 5 years, for example, ovarian cancer risk can be decreased by 80%, endometrial cancer risk can be decreased by 80%, and similarly, colon cancer. Breast cancer, little bit increases, but at the end, it is more cancer protective, especially for fatal cancers like ovarian cancer, endometrial cancer. What is your opinion, combined oral contraceptive versus hormone replacement treatment?
I think it's a good option in the younger age when the contraception is still an issue, or we have this protection, or there are some studies which make the comparison for the primary ovarian insufficiency group. There's another group of patients, but it was said that even with it was this protection of the bones.
Yes, yes.
I mean,
you can also use as a B alternative these drugs.
Yeah.
Maybe one message to our patients about phytoestrogens. I see many of cancer survivors feel that these plant-based, soya-based, soya blah blah are safe, but I don't think so. Estrogen is estrogen at the end, either endogenous, exogenous with a drug, or exogenous with a vegetable. I don't know. I mean, who is using these natural plants as estrogen source? Have you ever tried? What do you think? Are they safe? If you use
I think
soya.
we have to take some more, studies, and I think they have potential, because it said they have some estrogenic effects, but also anti-estrogenic effects, like they are competing for the same receptor. And I think if we have this randomized controlled trial and can prove that they can be used safely, maybe it could be alternative for breast cancer, like in this special group where we cannot give the hormonal replacement therapy and the women still suffer